Same disclosures. I'll just skip those. So adult deformity we've been talking a lot about, so I'm going to go a little bit fast through some of these things that we've already heard about a little bit just to try and get us back on time a little bit. So we're talking about scoliosis, kyphosis, and then the iatrogenic deformities such as flat back deformity. Well, I was just talking about single position surgery. That might bring that whole back right into our world. My concern with, and we'll talk about it in the positioning a little bit, with some of those is you got to really pay attention. If that patient has lordosis to start with and you're maintaining it, great. If you're trying to gain it, you're losing the battle if you have them in a lateral position. So complications are high in these surgeries still. Even with our better techniques, getting faster, getting better, getting less invasive, complications are still high. So this was a national inpatient sample study that looked at primary and revision adult deformity surgery, 47% in primary and 72% in revision surgery. So, and you know, these databases always underreport things, right? They're just looking for codes. This was actually a really nicely done study out of Vancouver. The group up there looked at a 12-month prospective registry. So they actually track their patients prospectively, which we know gives us better data. 942 patients for the year, and they tracked every single one of them. 58% of those were elective cases. So a fair percentage, maybe that's a pretty high non-elective number, but still a fair number of elective cases, and they're looking at these complex spine surgeries. They looked at the year before, so they went back and looked, well, what does our year before look like? 23% complication rate. When they track it prospectively, it's actually an 87% complication rate, 14 mortalities, 14% intraoperative adverse events. So that's high. That's CSF leaks, that's nerve monitoring changes, and neurologic deterioration in a deformity patient, so it's over 5% with about a 5% dural tear rate. So not insignificant. So we need to pay attention. That's why this talk is about how do we reduce complications. Well, there's lots of steps to correct a deformity. I put this in most of my talks, right? And that's how I think through it. All of these different things have to happen to do this correctly. And sometimes we're living in you know, one world, like intraoperative stuff versus, you know, patient balance and all the rest of this here. Those all factor in. So where do complications occur? Well, they occur intraoperatively. We can put screws in the wrong place, like that nicely placed S1 screw. They can occur postoperatively. But a lot of those complications start in the preoperative planning process. So you can preempt some of those complications with some attention to detail up front. So preoperative, where does it come from? Inadequate assessment of alignment is a big one. So not knowing what you need to get in terms of correction, and then you go and do a surgery, and if you didn't know what you needed, it's hard to end up in the right spot, and you lose the battle there, and you get a patient like this. Inadequate medical optimization is a big one. I always tell people, we're not going to make you like a superstar athlete coming into a surgery, but we can optimize everything we can, and we should be actively trying. You see lots of patients coming like, it hurts too much, I can't walk, I can't do this, I can't lose weight, I can't stop smoking. You know, you say, listen, if you want this to work out and work well, you've got to buy into this. I'm going to do my part. You have to do your part. And sometimes that takes a while. And inadequate evaluation of bone health is a killer, right? You've seen cases during this week about patients with bone health issues, and you see the failures. You cannot beat bad bone. If somebody has terrible bone, I don't care what their pain is, you are not going to win on that. You have to treat the bone first, get them into some sort of protocol, or it's just not going to work well. So intraoperatively, positioning. Poor positioning is a big thing, right? So this is a common thing. You already see patients, if you're doing fusions on a Wilson frame, right? Look at this person. That spine is designed to flatten out that lumbar spine. If you're doing a fusion in that position, you're asking for a flat back. You might get away with it on one level, short term, because they're not going to notice it. But if you're doing multi-segmental fixation like that, particularly down to the sacrum, you have to be very, very careful. Nerve palsies from poor positioning, ischemic optic neuropathy we talked a little bit about. So a head down position in a long case with a lot of blood loss is the high risk group for blindness, and you never want to see that. Poor hemostasis intraoperatively. Blood loss leads to complications. The more blood loss you have, the more transfusions you get, the more stress on the system, the more the medical complications. Absolutely. So if you can reduce blood loss, reduce transfusions, you will reduce your complication rate, you will reduce your length of stay. Poor tissue handling, leaving retractors in for an extended period of time, right? Every 15 minutes or so, you need to be loosening up and repositioning those retractors. Not irrigating your field throughout the surgery, right? Those are all little things you can do. That's attention to detail stuff, but that reduces your infection rate. Ischemic tissue, doesn't heal well. You don't get the antibiotics running through there. You don't get the, good white blood cells and everything else fighting infection in there. You just get dead tissue that doesn't have anything, and it just allows bacteria to grow. Malpositioning of implants, obviously we talked a little bit about, and we'll talk more about that. Dural tear, that's an attention to detail thing. Sometimes it's an anatomy thing. If somebody's high risk, their ligament is calcified, and you know you're gonna have to peel that off there for decompression, tell them you are at a high risk of a CSF leak. I quote people, I say all spine surgery average rates are about 5%, but certain groups are in the high risk group, and I make sure I counsel them preoperatively and tell them they might get a lumbar drain. And then spinal cord and nerve injuries obviously are huge issues. So postoperatively, where do complications come from? VTE is still a complication. Make sure you're using sequential compression devices in surgery from pre-anesthesia onset. Chemoprophylaxis is something I use regularly that we use in our institution. It is controversial still for some reason. I start all of my surgeries on post-op day 1 on prophylactic dose Lovenox first the morning after surgery, and I've never had an epidural hematoma. Inadequate nutrition is really a big deal, particularly in these deformity cases. If these patients are getting these anterior, posterior, and they're not eating for a while, their nutrition really suffers. Poor wound or drain management is a big deal. And then lack of supportive services for patients in the hospital and then transition to home. If they don't have good care to help them through this, you're asking for trouble. So how do we really reduce complications, right? Some things just exist. Patient has diabetes. Well, they have diabetes. That's a risk factor. But what can you modify on those? So I always try and think about what are modifiable versus unmodifiable risk factors, and you need to focus on the ones you can do something about. So pre-op things you can do, smoking status. We know smoking is bad for fusion, it's bad for recovery. People need to be non-smokers. And you can't just make them quit smoking. That doesn't really help you very much. It might help your fusion rate if they stay nicotine-free afterwards, but your risk of pulmonary complications, pneumonia, bronchitis, goes up when somebody stops smoking. It takes 8 weeks before that comes down to a smoker's baseline, and then after 8 weeks, that improves. So if you have somebody stop smoking 2 weeks ago and you take them to surgery, their risk of having some respiratory issues under anesthesia actually are pretty high. Mental health screening is something we don't do very well with at all. Yeah.
I tell people that all the time.
That the benefits of smoking cessation are achieved when you've been off cigarettes for 2 months prior to surgery.
Yep.
But I don't actually know where that comes from.
I have it somewhere, not in this talk probably. Yeah.
Yeah,
right.
This is documented in the pulmonary literature. That's what you're saying. Yeah.
Yes.
I just don't know where. I don't know the source of that, even though I've been telling people that for 15 years. So.
Yeah, it's not spine surgery. I think it's anesthesia with pulmonary complications. It's just from being intubated. But yes, so when you stop smoking, all those little cilia and things that haven't been working in your lungs, you start sweeping all the junk out, you start coughing up all that stuff, it's a nidus for infection. So your risk goes up before it comes back down. I tell people if they've been off for 8 weeks, their chances, one, of pulmonary complications have come back to smoking baseline and are getting better from there. And they are much more likely to stay off afterwards. If they can do it a couple months beforehand, they're much more likely to hold on afterwards and not go back to it. And I urine nicotine test everybody before surgery, and they're told if they fail their nicotine screen, it's back of the line. They can start over. They have to now pass a urine nicotine test before they even get rescheduled for a surgery. We're talking about mental health. We know depression is one of the highest risk factors for poor outcome after any spinal surgery. So it's untreated depression. Treated depression, just like the general population, untreated depression has a very high chance of reducing your outcomes. Bone health is a key, which we talked about. Obesity and nutritional status is a huge factor. Above a BMI of about 35, we see infection rates start to increase. Above 45, they go up even further. We do MRSA decolonization on everybody. And then surgical planning. What are we going to do? How are we going to do it right? Do I need to do a PSO on people? We know that has a higher complication rate, so if I don't need to do that, I can help reduce that as well. Getting appropriate correction and plans, and then what am I going to do for PGK prevention, rod fracture? How am I going to prevent those long-term complications as well? So that's a lot, I know, but it's something that you need to think about through that pathway, through that process with every patient. So we have some preoperative guidelines. Yes?
Several of the faculty have brought up mental health, how you do some of the screening, and then how do you handle those patients that you find out there?
So that's a good question. So we in our clinic don't do an actual mental health screen, which we probably should do a better job of. Our preoperative pathway, so we have a preoperative service that sees all of our patients. We're supposed to put them all through there. They will do a screen. If somebody is screening for depression, anxiety that is untreated, getting them treatment can be really difficult, actually. Getting them like a doctor that's going to help them manage that really matters. But if I know somebody has, if I think they're high risk, they have a diagnosis that's high risk, I say you need to have, be undergoing treatment and have a doctor that is going to treat you afterwards, right? We have to identify whether it's psychiatrist, psychologist, primary care doctor, whoever's managing it, somebody that we know is in charge of helping them through their mental health. Because if it's bad before you put them through a surgery, I put them through T10 to pelvis and they can, they're moving around slow and they feel stiff, it's going to get worse before it gets better, and they need somebody identified to help, and that seems to make a difference. So we have a pathway and a protocol for preoperative guidelines. So this is, everybody knows what these are, so that makes it easy. A lot of those little check boxes we have, I don't need to think so much about them because they're getting screened for as a part of the standard preoperative process. An elective spine surgery at Northwestern is supposed to meet these criteria. So BMI less than 35, which is an interesting conversation sometimes. Vitamin D levels, which are notoriously in the Midwest low, so we screen for all of those. Diabetes controlled with an A1C of less than 7.5. Albumin of greater than 3.5. That's a really poor nutritional screen that is controversial. We do a nutritional screening 3-question test in the preoperative process that triggers a nutrition evaluation. There's no one good way to screen for nutrition, it turns out. If we talk about doing pre-albumins or total lymphocyte counts, there's always somebody that says, well, this literature says that's no good because of this. We use albumin because it's a number we can look at, and it's an easy one to screen for, but it's not the perfect. The moral of the story is you need to pay attention to the nutritional status. Your nicotine is negative, and then medically optimized, which is a whole much more vague scenario. We do a frailty screen in that preoperative clinic, and they screen frail. You need to be.
Tyler, can I give a news flash?
Sure.
I feel like incoming shocking news. That article is based in a 1990 article that when we were residents, you and I probably read. They just ripped it apart. There's an article in JAMA, I'll send it around to you. They did a meta-analysis on all the studies, using 9 studies, and showed that there really isn't a big difference when they stop smoking. And the 8-hour thing is a historical thing that 8-week thing was a historical thing that's probably not as justified as it should be.
I'm sticking with 8 weeks.
The 8-week thing.
I'm not saying to change it, but listen.
Interesting, yeah. I'll put that in.
I think it's just,
Senor.
they've gotten better at managing it, but there's that effect.
But I mean, the funny thing to me about this, and I'm just going to say that, it's unbelievable how we learn something and we just stick to it as fact, and we all jump on it, and
Feels good.
we're idiots. It's all lies.
It's practically very helpful, though, this 2-month thing. That because the likelihood of, like you said, the likelihood of they're staying off cigarettes is obviously higher if they've been off for 2 months and then it's been off for a week. So it turns it into a team sport.
It does, and your constantine levels test for weeks, right? You can get a positive that drags out, so that actually fits with that paradigm as well. Do you have a question?
Oh, yeah. So you mentioned you're nicotine negative.
Mm-hmm.
I mean, most people, when they quit smoking, can't quit smoking. They usually go to some sort of nicotine replacement.
Yep, they got to get off.
Yeah, entirely.
Yep. So smoking's bad for the lungs, nicotine's bad for your fusion, and they got to be off. The same being off for 8 weeks allows them to stay off afterwards, right? Because their stress levels are going up. That's what they go back to smoking for. We don't want them to happen in the postoperative period. Yeah.
Sorry, what patients are these for? These for everybody, one level fusion?
Everybody. So this does not apply to tumors, cord compression, neurologic deficit, right? So things that are non-elective, but elective spine surgery, yes, this applies for. And I make our residents, right? So I run the spine program, and getting people to agree to all these things they agree to it at a meeting, and then somebody comes on and like, well, I don't want to cancel a case. If they get a wound issue, all these numbers go up on their M&M slide, and we say, how come you didn't do it? And it took like a month or 2 before like those numbers dropped off, like people fell in line. So intraoperative factors, minimizing blood loss using an experienced team, whether it's a good assistant, whether that's resident, fellow, 2 attendings, depending on the type of case, making sure you have an anesthesia that's well experienced. Using TXA is helpful for blood loss. Attention to detail, protecting the neural elements, all the just good surgical techniques. Following your 10 commandments really helps. Infection prevention, what do you do for that? And then accomplishing your alignment goals really matters. Postoperative, make sure your medical team is involved and invested in these patients doing well. Having a consistent medical team that works with them really helps, that knows your plans, how your patients really go, what those protocols are really matters. Again, DVT prophylaxis is key. We know it helps reduce VTE rates. Early ambulation is probably the most important for that, and then having a protocol really matters. So alignment goals, I'm not going to belabor this. I'm going to skip over most of this, but we talked about it earlier. Dr. Okonkwo talked about it yesterday. Coronally getting lined up straight over the pelvis. Sagittal plane we discussed, and I'm going to skip some of these slides just to get us through, since you've already been through some of this. I'm showing how I generally measure what I do. Getting appropriate fixation is something we take for granted, and with technologies that are advancing, we just put screws in. No, you need good, strong screws to do deformity. If you look at this person right there with a really rotated spine, kind of an atypical type of curve, and we get a CT scan and we look at the pedicles that look like this, and we need to get a screw in there. So this is that screw going in that patient, and if you look at with the rotation and the size of that pedicle, like if you put a screw in that's that medially oriented, that's going right through the spinal canal. But, right, if you need to localize to your actual spinal level to be able to put that screw in, right, there's no fluoro, there's no nav, there's just a screw going in there, and that's that screw going down that pedicle, right? So you need to be able to put screws down those tracks if you're going to correct deformity and pull that around. So you need to be able to do that and do that safely. And then, right, that pulls around to that. So if you have good, strong fixation, you can pull that around. So if you miss screws, what do? There's a variety of techniques, and I would recommend in the lab today, if you're not comfortable putting in screws, put in as many screws as you can. If you are comfortable putting in screws, miss some screws on purpose. Feel what it feels like to breach it medially. Feel what it feels like to breach it laterally. Try and salvage a screw. That's really like a advanced technique to be able to do that and feel that. That would help you out a lot. But so using other things, so if you look at some safety of these, there's a bunch of studies when thoracic screws came out, like, oh, can you really do it? Saying yes, low malposition rates, but if you look at this, like, oh, they had only 1.5%, but transient paraparesis, dural tears, pneumothorax, those are big deals, right, just from putting in the screws. Some complication types, you see all of those there. And then you see all these studies that start to show you, like, screws, like, that's not so bad. Another study looking at the screws, again, scoliosis screws, so not easy to place. A low percentage of misplaced screws, but mostly done by X-ray, so that's not a very good way to study that. But significant dural tear rate, 12.1%. Pedicle fractures, 13%. You get screws that are starting to go out into the lungs, getting pleural effusions. You start to say that's not so great. So you have to be able to place those screws and place those well. Another one looking at some medial breaches, where what is safe, what is not safe, how medial can it be. The study was only 93.3%. We're in the acceptable range. Going out the front, there's no safe zone, but if that's at a level where your vessels are right there, that over time is going to create a problem. And you can see this here. There's a nice CT angiogram with the screw right in the middle of that. Nobody wants to see that. And then they have nice intraoperative photos from, like, that's, so I don't know if you can see that right there is the defect in the back wall of the aorta, and that's the screw that was sticking into it. Another nice one, this is right when this picture has your aorta cut in half, looking at the screw on the inside of it, not great. So everything carries with it some risk. Here's a bunch of different risks of that: pneumothorax, CSF leak. So, right, the thing about deformity surgery is the screws are not the hard part. The screws are not the hard part of the surgery. All the rest is the hard part. So you need to pay attention to detail, even on, right, something that seems like it's getting kind of routine for you. It's never perfectly routine. So looking at some of the morbidity and mortality from the SRS, where we have to submit M&M data each year as being a part of the society, looking at sagittal plane deformity, These are big operations. PSOs, VCRs, and PCOs are posterior column osteotomy. So instead of saying Smith, Peterson, or Ponte, you can just say a PCO and stay out of the politics. But if you look at the complication rate, the bigger the surgery, the bigger that osteotomy, the bigger the complication rate. It goes up from 28 to 39 to 61%, the more anterior work you're doing. Here's one looking at PSO and VCR. PSO had higher complication rates in this study looking at that with greater sagittal imbalance. You can see the blood loss numbers are pretty high. 1867 is the average on a PSO case. That's a lot of blood loss for anybody to tolerate. Long operative times. Again, we'll skip over some of that. PSO generally gives you a better SVA correction because it's done in the lumbar spine, where VCR gives you focal angular correction. So I'll skip towards the end here. So when we talk about medical risks, what can you do? You need to have your medical doctors. We need to know what we're kind of looking for, and certain things come up high risk. Somebody comes in, they've had a liver transplant. Okay, they're a high risk surgical patient. But cardiac, pulmonary, always beware of the hepatorenal, lung, liver and kidney problems. People just don't act well with a big stress on their system. Nutritional and psychosocial issues are something that we sometimes miss and we need to really pay attention to. So we have a protocol. We have this Northwestern high-risk spine protocol that you may have heard about. Started with an adverse event in 2005, an intraoperative death. We put together a multidisciplinary team, and by 2007, we had this protocol rolled out. So our risk factors for what makes somebody a high-risk spine patient is a surgery that's greater than 6 levels, planned for greater than 6 hours, anything that's anterior, posterior, anything that's staged and age greater than 80. So you can be having a microdisc. If you're age greater than 80, you flip into the high-risk protocol. So again, started in January 2007, and this is a preoperative, intraoperative, and postoperative pathway. We've got all these little graphs on what are high risk, and there's some high-risk medical things that are listed there. So coronary artery disease, congestive heart failure, cirrhosis, dementia, emphysema, renal insufficiency, pulmonary hypertension, stroke, and then that age greater than 80. So all of those are medical high-risk triggers. And then it goes through a pathway, through our preoperative process. We meet and discuss the details of those cases. We do it virtually now with email and EMR-based discussions, but oftentimes there can be in-person conversations. They're sort of on a one-off basis where we don't have our regular routine. Everybody used to have a face-to-face meeting. We don't do that as often for a variety of reasons, but using the EMR to leverage that has gotten a little better for us. All the different things that we do, the anesthesiologists have a separate form they're checking off in surgery to make sure they're following protocol. We do little things like we don't give FFP anymore in surgery. We found that patients were getting FFP, a ton of it. For coagulopathy, they come out fluid overloaded, they stay intubated, they go to the ICU. Now patients get cryoprecipitate only for fibrinogen triggers. We don't treat INRs and other factors, and our percentage of patients that stay intubated after surgery went from probably 80% of patients staying intubated after an adult deformity to maybe 5% or less staying intubated these days. And then all those things, even things such as OR temperature to make sure those are protocolized, warmed fluids, little things to prevent people from getting too cold during surgery. There are lots of little things that can optimize, and there's no way I'm thinking about all of these while I'm getting ready to do a big surgery. That's why it's all written out, and that's why we go through there, and that's why we've got like sort of a check and double check process. And again, from the postoperative pathway, what they get in the unit on the floor, what they have to do post-discharge, where we check various labs. Again, they're all on there. This is all in the literature as well. So we have a ventilator weaning protocol that triggers if somebody does stay intubated, transfusion protocols, and we adjust these. Like every 2 years, we sit down, reevaluate, and readjust. So the question is, like, for us, does it work? Do we maintain it? Do we update it? We've got a few publications on that. This one showed a high acceptance of the protocol. So we have all of these anesthesiologists. When we looked at a couple of years worth of data, we had more than 30 attending anesthesiologists that were in our cases, greater than 100 residents and CRNAs rotating in and out, and only a 2.6% protocol breach. So all the things they're supposed to do, only 2.6% of the time did they actually breach protocol, which means it was easy to follow and the pathway system works. We looked at predicting major adverse cardiac events, which finding the standard workup is relatively poor. A variety of different things. So things that are obvious that it helps, we decrease our postoperative edema. We get people off the ventilator earlier, which we know reduces complication rate, reduces length of stay. Earlier identification of medical issues so they can be treated up front as opposed to becoming a lingering issue. Our communication's better, our transfusion rates are down for sure, and we need to keep going through. So wrapping up here, things to think about in surgery, first and foremost, yeah?
How do you manage the fluid in trial? Always been a problem. You know, when I do a lot of 2 stages,
Yeah?
it's not unusual that the second day, every time you open the skin and you get to the subcutaneous tissue, you see all this watery, you know, and you know that it's a lot of third space. And in the first day, you know, day before, I was very careful, you know, with the fluids and that, and still it seemed like a air overload. Wanted to know where we lose control of that.
Yeah, I mean, right, we know, like, patients are third spacing fluid all the time with the stress of the surgery. They're getting a fair amount of crystalloid in addition to the colloids and other things they're getting. We try and run a little more colloid heavy, but there's, you know, between the...
Any protocol or kind of, this is the max volume that...
We don't have a max volume, but it's something they're paying attention to, right? It's our sort of anesthesia team is using colloid if they're trying to press things, but we don't have a set like, oh, you can only give so many liters of this, right? 'Cause we're also trying to maintain mean arterial pressures in certain, you know, we're doing a cord level osteotomy, we're pushing things and they're using fluids. So we actually have a issue the other way, quite honestly. Our patients are coming out a little dry sometimes, which is all bad on the other side, right? Coming out dry is a stress on their system as well.
And when do you transfuse in trial? They say you're doing a big deformity case. What
Yeah.
do you say, give it blood?
I mean, our trigger is always 8, but if it's, right, if we're 8.5 and I have a lot of work to do, they're ordering, right, they're gonna start hanging something and dripping it in. What's that?
How much?
They're giving a unit at a time. They're just one at a time. But most adult deformities, I'm trying to get them through that case without a transfusion, right?
For our MIS cases, it's just radically different. By and large, it's 1-to-1 for blood loss and transfusion in our open cases.
You'd say 1-to-1, so,
1 cc for 1 cc. So if someone loses 800 cc's of blood, they're going to get a unit.
and their starting hemoglobin was 14.5, you're still gonna give them a unit?
Yeah.
You would?
14?
Well, first of all, I never see a hematocrit for
After
Yeah.
1 liter of blood loss.
No, but we have a preoperative anemia pathway too that we, like, I want more than 11 to start, but people get iron infusions in our preoperative clinic regularly, trying to bump them up to get them up above there to see if we can avoid doing that.
Because this happened to me like a few weeks ago. You start the case, actually it was 14 pre-op. And then in the middle of the case, you ask, you know, what is the blood loss? 200 cc, something like that. And then the anesthesiologist is telling you that the hemoglobin is 10. You know?
Yeah.
And then 2 hours later, it was 8 point something, and the blood loss was like a 500 cc's. So the question is,
It's mostly
well, I
delusional.
mean, no, it's not retroperitoneal hematoma, but the question is to me always is hard to get, you know, with anesthesiologists that communication, you know. Why this patient is getting hemodiluted because I don't have too much blood in here.
Right.
I mean, can you give it blood instead? And they say, well, the hemoglobin is not that low. Why are we gonna give it blood? I mean, what is the indication? It's just
Right. I mean,
how you do it.
I never. We looked at our complications in our blood, and we actually, if you give someone blood, and this is uniform in medicine, you actually have a 3 to 6 time increase in complications,
Yes.
independent of any other factor.
Correct.
So even if you try to think, so there's blood is not a very good thing. We used to. I let their hemoglobins go lower than you would imagine. I mean, if they're asymptomatic, they'll be walking around with 7s and 6s, and as long as my cardiologist isn't having a stroke, I really have not, because I found what you found. They come they're dehydrated the night before. The anesthesia team gives them 7 liters of freaking blood of fluid. You know, and now their hemoglobin goes down to 8, but it's like if you give them Lasix, it goes up to 20. So it's like.
And I like what you say because actually we're trying to write a revision article on people tend to think, especially the open SRS old-fashioned guy, they think that transfusion doesn't mean anything. I mean, not even often. You ask a Rich SETI, you say, you transfuse, and transfusion doesn't have too much problem. And then I'm trying to put a revision paper actually showing that transfusing people actually has a lot of risk, and it's not as simple and as stupid as you think.
It's an independent risk factor for complication whenever it's looked
Put that
at.
one in our own literature,
Tyler, a quick question and a comment. So, as you know, historically, deformity surgeons have always taken significant pride in being able to hit every tiny type D pedicles, whatever, freehand. And some of them still up to today frown upon folks that rely on some kind of intraoperative imaging. My question is, do you think that there is a role for at least some form of advanced imaging intraop, not necessarily to rely on them to, let's say, hit your pedicles, but at least to check your instrumentation prior to leaving the OR? Because I think in this 21st century, we shouldn't see misplaced instrumentation on the M&M list.
Yeah,
I don't think that's acceptable.
I agree. So we have 2 arms and an arrow. So I said, right, so we had not one of mine, but in M&M a couple months ago, a misplaced screw. And I said, there's no reason we should ever be having a misplaced screw M&M. We've got the ability to image those screws in surgery. If you're not 100% sure, you need to check. On my deformity cases, every CT, so after all my implants go in, I get an O-arm spin. Like I stop, I break, I get a spin, I look at every one of them. So routine.
So for the fellows that are negotiating for jobs, would you recommend then that instead of negotiating for the extra $50,000 or $75,000, instead they should probably negotiate for something like intraop CT if they don't have one?
Yeah, I mean, I think that's an important thing. Like, not everybody always has, access to certain technologies, but it certainly is helpful. I think. So I think a misplaced screw in this day and age is probably not acceptable.
So it's interesting you say that because I just put one in the middle of the canal. The interesting thing is we have an O-arm, and it's really helpful when they have a sheet fusion over everyone. And so we use it. We become very comfortable with it. And life's always about your checks and balances. So I did a case, and it seemed accuracy. I didn't check the accuracy as great as I normally did. I put the screw in, and I'm like, that feels like, bone water is coming out of the hole. You're like, oh, that probably doesn't sound too good. And so what I learned, and I've actually had other people who's had this experience, if you use the O-arm, there is a drape that you can put on the patient versus on the O-arm.
Yeah, I
drape
the patient.
The interesting thing with that, and we have an older O-arm, and I don't know what it is, but Eli Barron called me up one night, and he's like, I just put a screw through the spinal cord, and I think what happens is if it's not perfectly flat across the trajectory, your image guidance can be off. And so I actually stopped using it now because it's happened to me several times where you do your scan, everything's fine, and the registry just isn't right.
You're talking about navigating. I'm talking about just checking screws at the end after they've been placed. Navigation's a whole separate thing, which navigation is a platform that's getting better and better. But
so my only point is if you use navigation, make sure you check it ahead of time, and then you should do. You should be very careful if you use that drape.
So you don't have navigation, you're off the hook, right?
Yeah. And I can tell you, if you use navigation, Jim, some way that you can actually prevent the lack of real-time information is I like to keep what I call the sentinel X-ray. So I keep an AP fluoro very high, and every time I get the entry point on the navigation, I take one shot, make sure that it makes sense, and then I go. That way I keep that X-ray machine is like the checkpoint reality type of, and actually works very good. And you keep it very high on the field, just giving you an APs. So make sure that your entry point matches what you see there, and then you just keep going.
I mean, you got to make sure whatever you're doing it safely. Navigation is a whole separate discussion, right?
Exactly.
There are so many nuances to navigation and doing it right. I always tell our people, when you're doing something to the spine, you're looking at the spine. Like when you're staring up at the screen, and you're pushing on the spine, like the screen's just lying to you. Why do you want to look at it when it's inaccurate, right? It's only accurate, you can sort of stop, pause, there's no pressure, nothing's pushing. So it's drills and power and things to put screws there. It's not, like they make a navigated Lenke probe, dumbest thing ever invented.
That's a good point. Navigation is all about power tools.
No, yeah,
and,
it's
not moving the patient around.
right.
How are you checking your deformity correction after it's done?
So I do one of two things. I do a full-length 36-inch film, intra-op, AP and lateral. Yep, on the table, and I break every time and measure it myself. Or I do, now if I do an ORM spin, so if I have all my implants in and my rods are in and it's not yet noon, so I do, my ORM spin happens before noon because I don't want the x-ray techs going on lunch breaks.
You're not
So,
using the computerized stitching technology,
I'm getting there. So if it's 11 o'clock and all my screws are in, my decompression is done, my T-lift is in, I put the rods in, I call for the ORM. So then I do an ORM spin, make sure it looks okay. I always ask the resident fellow, I'm like, are you confident? Are they good? And if they say yes, then I put the rods in and do the spin. If they're like, then we do the spin before the rods go in. But if I have the rods in, then I stitch the ORM films. You can stitch on the ORM now to create a virtual long cassette film, which actually works really well. There's some nuances to that too, but that works. So I stitched that. We're trying a less ray this week, so I'll see how that works. So just
That's the virtual T-bar.
yeah.
Tyler, a little off topic, but do you have any experience with the hinge table for closing osteotomies? Is that
I use the hinge table on all my cases.
You do?
I do.
And what's your experience with that? Is that in your hands? Do you think it's a safer way to close? Does it protect your implants? Does it?
It's certainly a safe way to close an osteotomy because you're not putting the pressure. The pressure's not on your implants. So you're not preloading any force there. My general workflow is I flex that table up into 20 to 25 degrees of kyphosis. I do all my work. I flex it down into plus 10 and rod there. I usually do not bring it to zero. That table is very powerful. If you bring it to neutral, most people are overcorrecting with that, and you're just setting yourself up for a PJK. So I usually rod at plus 10, unless it doesn't look right to me, and I think they need a little bit more. If I'm doing a 3-column osteotomy, I might bring it down to zero because I'm trying to push that close. I'm trying to get everything all at one spot, and I know how much I cut, so I'm just going to try and close it fully. But I'm cautious with how much I close that because it's powerful. But I do my T-lifts on there. I do my deformities on that table. Anyway, we're now over, but I was on time. So yeah, level selection is key. PJK prevention strategies are key. And knowing when to say no. Not everybody needs an operation, right? If they're not prepared for it, you can be ready as can be and able to execute it. If they're not ready medically, psychosocially, if they just don't understand what they're getting in, don't do it because it'll get you in trouble. So thank you.
All right, thanks, Tyler.